Welcome to the webinar, Prosthetic Abutment Design and Dental Implant Therapy. This lecture is being presented by Ibrahim Dukum, DDS, MS, FICD, and we will begin shortly. And with that, it is my honor to introduce Ibrahim Dukum, DDS, MS, FICD. Ibrahim Dukum is a professor of prosthodontics and the chair of the Department of Restorative Sciences at UNC Chapel Hill Adams School of Dentistry. He completed his DDS degree at the University of Jordan and earned an MS in prosthodontics from the UNC Chapel Hill in 2008. He is a fellow of the International College of Dentists and the ADEA Leadership Institute. A published author, Dr. Dukum lectures nationally and internationally about all aspects of prosthodontics, aesthetics, and dental implant therapy. And now it is my pleasure to say, take it away, Dr. Dukum.
Thanks, Jessica. Appreciate the kind introduction. Good afternoon or evening, everybody. It's great to be with you here today to discuss a very important topic when it comes to implant dentistry, talking about prosthetic abutment design. So, first of all, I have to disclose that I'm receiving an honorarium from NDX for this presentation. Otherwise, this presentation has no any other commercial support. There's nothing to disclose beyond the honorarium. As far as the objectives, today we will discuss prosthetic abutment design, trying to understand the desired feature for dental abutments in general, and how we can utilize different materials, different designs, different workflows for the utilization of dental abutments in dental implant therapy, and then try to apply the selection process for dental abutment to achieve reliable clinical outcomes for our patients. But the role of abutments in dental implants is extremely, extremely important. It is that part that connects the prosthesis to the implants. It's the foundation to provide support for functions and aesthetic. And it permits actually the reestablishment of the biological width around dental implants, which has a huge influence around or for soft tissue health and aesthetics. So dental abutments, some of the desired features for them, it should be mechanically sound to support full-time function for the patient. It should be inherently aesthetic, and that could be through the material it's fabricated from, the design it's made from, and obviously the placement and all the related prosthetic features that is related to the abutment design and the prosthetic design. And of course, it should support peri-implant mucosal health, again, for the function and for the aesthetic of the dental implant. It's also very important to transmit forces to the bone, try to minimize the amount of stress at the implant abutment interface. And by that, we can probably have better implant health long term. It supports the prosthesis. Very important that it can control biofilm accumulation. And that has to do with the design of the abutment, the transmucosal design of the abutment, the polishing of the material, any way that actually allow less accumulation of biofilm and thus less chances for peri-implant mucositis or peri-implantitis down the road. It's very, very important to have a very stable connection for the dental implant abutment, absence of micromotion, and again, like we mentioned, reestablishment of the biological width. And the abutment generally should be physically robust, so it can support function and aesthetic and have pretty much similar anatomic features to what we expect from like a tooth preparation supporting a restoration. But to have a good peri-implant soft tissue health and stability, that has to do with a lot of factors. It has to do with biological factor that's presented by the patients, things like bone availability, bone quality, soft tissue architecture, and the presence of keratinized gingiva. It has also to do with the surgical procedures, the technical procedures we perform to restore the dental implants. And of course, something that's very, very important is biomechanical factors, loading patterns, micro gap accumulation, implant design, abutment design, and the micro gap that exists between the dental implant and the abutment, and where is that located and how it relates to the tissue health. The stability of all of these factors result in very good implant tissue health and the maintenance of that long term. Now we start talking about the type of abutments that are utilized in implant dentistry. Obviously, there are stock abutments. These are pre-manufactured and limited in customization. However, we use those for years and they can be successful if they are selected properly. For example, here, this is the direct abutment from the Astra system. There are the custom abutments, which can be fabricated through CAD/CAM technology, and these are tailored to patient anatomy. So they are pretty much patient specific. And those are probably most of what we use in dentistry, at least in my practice, are probably for single unit restorations or fixed dental implant prostheses. Those are what we utilize most of the time. They provide huge advantages from tissue support to tissue health, control of the location of the margin, and thus control of the cement around dental implant, but also give huge advantage from biomechanical standpoint, but also aesthetic standpoint. Nowadays, also, there is a lot of tie bases that are utilized to manufacture dental implant restoration, whether in screw retained fashion or cement retained fashion. And those are provided particularly with the use of CAD/CAM technology in chairside fashion, but also utilized with lab made or lab supported restoration. So there is a lot of options when it comes to implant abutment design. Also, there are a lot of materials that can be utilized. The main two materials that are utilized in the manufacturing of dental abutments nowadays are either titanium, which is a very biocompatible material. It's strong, it's widely used, and it's provide the advantage of having or maintaining a titanium to titanium connection inside the implant or inside the implant interface. These can be the regular shade of titanium, or they can be gold plated, which provides some aesthetic advantages without compromising any of the biomechanical features of the abutment. The second material that's widely utilized is zirconia. And zirconia is aesthetic. It is suitable for probably the anterior regions, although it can be used throughout the mouth. It can be a one-piece zirconia, similar to what you see in this picture, meaning the whole abutment, including the connection, is made in zirconia restoration, or it can be a hybrid abutment where we have a zirconia sleeve pretty much cemented to a tie base to maintain a titanium-titanium connection. And that's what we have in the hybrid materials, similar to what you see in this example. Now, in your practice, you probably have to utilize most of these options. You could probably dominantly use titanium abutments or gold shaded titanium for aesthetic reasons, but there'll be times where you have to utilize zirconia abutments or hybrid materials. So it's very, very good to have pretty much criteria for the selection of these materials. Some of the variable abutment features that are very, very important, things like the design of the restoration. Is it be cement retained or screw retained? So that's a decision that you have to make. And then how you can accomplish that for each option. What would be the best abutment material and design for that? Transition contour in the transmucosal area, how you transition from the dental implant platform to the restoration to provide tissue support and good emergence profile that result in better aesthetics and better function. Some of the biomechanical features for the abutments. What's the axial wall and what is the minimum that's acceptable for cement retained restorations, for example? That would be around 4 to 5 millimeter. What we'd like to have is about 6. But again, a minimum 4 to 5, and that's with a acceptable taper about 5 to 10 degrees that provide you with good biomechanical features and stability for the implant. What's the angulation of those implants and where the screw axis is located? That has to do with the implant placement and has to do with the restoration that you are trying to accomplish, or what the desired feature of that restoration is. And nowadays with CAD/CAM technology, actually, we can even redirect the implant angulation utilizing 5-axis milling and things like angulated screw axis or angulated screw channels to achieve better outcome, aesthetic outcome, and still have the screw axis, for example, coming through the occlusal surface of the posterior teeth or the palatal surface of the maxillary anterior teeth. Margin configuration, again, particularly with custom abutments that can be completely under your control or the lab technician control by placing the margin in a slight subgingival location. Color of the abutment, that depends on the material, and definitely with zirconia that can be manufactured with tooth colored restoration that provide huge aesthetic advantages for the patient. But let's look at prefabricated abutment. Normally, these are utilized for cement retention. Some of them can be utilized in screw retained, but they would require additional work by the lab, and we're going to discuss that shortly. Axial wall height, again, these are predetermined by the abutment design from the company, and what will change is the depth of the connection depending on the depth of the implant and the height of the soft tissue. Most of those are manufactured in titanium. But again, if these are planned correctly, you can have very good outcome for the patient. So here is an example of a patient presented with vertical root fracture that would require the removal of the tooth and the immediate placement of a dental implant. A very important anatomic landmark would be the gingival zenith of that tooth. If I know where that is, I now can place my implant predictably about 3 millimeter deep minimum, maybe 4, so 3 to 4 millimeters, and about 2 millimeters lingual to that to preserve the facial plate of bone. So if I extract the tooth and place that implant and place, in this case, a prefabricated abutment that's utilized in the professionalization of that dental implant. Now I have an implant analog that I can utilize outside to complete and finish my provisional restoration. I can have immediate provisionalization, immediate support for the soft tissue, and probably more predictability with the healing of that soft tissue around a very good provisional restoration that's highly polished in the short term. And then later on, it can be replaced by the permanent restoration utilizing the same abutment and can achieve very, very good outcomes similar to what you see in this picture. So these still have place in dentistry and they can be utilized very, very successfully if we protect or if we respect the biology and follow, again, very strict protocols for implant placement and implant restorations. So we can achieve, again, very, very good aesthetic outcome. Now, for multi-unit restorations, we can use prefabricated abutment that are slightly different, that allows for screw retention, things like multi-unit abutment, which, by the way, nowadays also can be customized. If for any reason, there's implant angulation, there is spacing issue, these can now be customized through CAD/CAM technology. However, the features of the abutment stay the same. These are mainly designed for screw retained restoration. And also it will allow the passive fit of the restoration, particularly if you have multiple implants that are not parallel to each other. That can create a biomechanical dilemma for the dentist. And these multi-unit abutments, they have about 15 to 20 to 40 degree taper in some instances, which allow the correction of that lack of parallelism, and again, the passive fit of the restoration. So it is example of the treatment with multi-unit abutment for full arch restorations, which is one of the key features for the use of these abutments. Again, notice that they can be angulated, particularly for the all on X options with angulated distal implants, or they can be straight abutments. And again, they can also be even customized by your dental lab or manufacturing center. Obviously, you will need an abutment level impression here. You have to verify your cast when the cast is created. Nowadays, also, you can scan these with scan bodies for full arch restorations. And there is a lot of research in this area about the accuracy for full arch. And if you can connect these scan bodies together. So you're going to see a lot of abutments nowadays with almost flags that comes in the lingual direction that connects to a central point. So you can actually scan the implants and connect them from right side to left side. So you can have a very good inter-arch accuracy of your scan. And then you can manufacture predictably your full arch restoration. And nowadays with 3D printing, we can 3D print our provisional restorations and then move very, very predictably from the prototype print to the definitive full contour zirconia or PFM, whatever material you would like to utilize for these type of restorations. Now, in dentistry, when you start talking about custom abutments, remember that traditionally those will be fabricated by UCLA type abutment. So they are cast to abutment. So it provides a platform for the lab technician to build the abutment around. And nowadays, if you still need to manufacture a traditional screw retained restoration, that's probably still the way to go. However, we now utilize more CAD/CAM technology by milling the whole abutment with the connection that goes inside the implant. But again, these can be utilized for screw retained restoration, cement retained restoration. You can have a control about the transition contour through the design and the manufacturing of the abutment, the angulation, and even the margin configuration. And here's an example in which a UCLA abutment was utilized, cast to abutment to fabricate screw retained restoration with the cantilever lateral incisor with some pink ceramic. That was done very, very beautifully by my dear colleague, Dr. Deacock. And here's the final restoration for the patient, where you have a pretty much a complex situation, and that was done very, very beautifully and very, very predictably. Here's another example. This is one of my cases where actually we were planning to do a CAD/CAM abutment, but because of the shallow implant placement, there are certain parameters that CAD/CAM cannot and has to respect. And one of them is having a minimum distance from the implant platform to the margin of the abutment, which was not suitable here without actually placing the margin in a supragingival location. So we decided to just go ahead with a cast abutment with a full control of that by the lab technician. And that's how it was manufactured, resulting in a very good outcome for the patient, similar to what you see here. Now, zirconia and titanium prefabricated abutment, those are available and utilized. Those are prefab abutment, but can be prepared by the technician or by the dentist to fabricate more customized restorations. Those were more, I think, famous in probably about 15 to 20 years ago, before CAD/CAM abutments came along. However, you can utilize them in cement retained restoration. You have very good control on transition contour, the length of the axial wall, and the margin configuration. And you can follow a very strict guidelines for these abutments. So here is an example of off-shelf zirconia abutment that was prepared based on the soft tissue profile that the patient present with, and you have control over the placement of the margin. So some of the guidelines that you follow, you would like to have a concave buccolingual configuration. You would like to have a convex transition zone coming from the implant to the margin of the abutment, and then the restoration. And you'd like to also provide pretty much a buffer zone for the soft tissue, so you're not actually pushing the gingival tissue too much, resulting in later on things like gingival recession and exposure of the abutment for the abutment margin. So here is an example of preferable zirconia abutment, resulting in a very, very nice successful restoration through CAD/CAM, chairside CAD/CAM technology. And here's an example of these abutments actually being opaqued and customized for better aesthetic with all ceramic type of restoration in the case of congenitally missing teeth, with also veneer restorations on the central incisor. And you can see that these abutments, they can be utilized for provisionalization, and then the final abutment that was used here was customized and even was shaded for better aesthetics, resulting in a very, very nice outcome for this patient. Now, let's move to the probably last type of these abutments, which is the computer-aided design, computer-aided manufacturing. These can be utilized for cement retained restoration, screw retained restoration. You have pretty much full control over the design, the transition contour, the placement of the margin, and the angulation. These come in different materials, titanium, zirconia, and they can come in different shades, and they can even be gold shaded. It's probably the abutment that's mostly used in implant dentistry for single unit restoration and provide very, very good outcomes for the patients. Again, they come in different materials. They could be zirconia, titanium, hybrid, but again, it's fully customized, and they are purely patient specific. If I look, for example, at the intaglio surface of this crown, I would have thought that probably this was done for a crown preparation, a very good crown preparation with even seating a groove. And what you see here is actually the intaglio surface of an implant restoration fitting on fully anatomic titanium CAD/CAM abutment. And if it's done properly with support of the soft tissue, very accurate placement of the margin, but also respecting all the features you need from a biomechanical standpoint to achieve good results for the patient, you can achieve very, very good outcomes. And these abutments are actually, they are associated with better soft tissue health and stability, particularly in the aesthetic region. This is very, very well documented with multiple studies in the literature. Also, the use of these abutment is very important feature in actually trying to eliminate excess or retained cement around the dental implant. We can utilize multiple strategies to do that, including using verification radiograph, radio-opaque cement, using retraction cord, during the placement of the abutment. But something that's very, very important to consider is the abutment design and margin location in that abutment in preventing and supporting the soft tissue and preventing retained cement around dental implants. And those pictures can illustrate that. So look at this abutment here and that abutment there, which is our fully customized CAD/CAM abutments, and look at the soft tissue support, the margin placement. They pretty much are fully anatomic, almost like a prepared tooth. Compare that to a prefab abutment where obviously the facial margins in a very good location and cleansable location. But what about the lingual margin there? And even if I use radio-opaque cement and take a verification radiograph, which mainly is two-dimensional. So if I have any trapped cement on the lingual side of that abutment, it's going to be blocked by the crown material, and the abutment material won't be able to see it. And years later, now we're going to start having problem with the patient with mucositis and bone loss, secondary to that retained cement around dental implants. So the customization of that abutment being patient-specific and the full control over placement of the margin and the support of the soft tissue is extremely helpful. So here is an example of a patient that actually I treated a few years back. Patient was living in Florida, receiving treatment in North Carolina. Then he fractured an anterior FPD. I referred him to one of my oral surgery friends in the Tampa area and sent the surgical guide. So he placed those two Straumann bone level implant. Then the patient came back, and actually the way we restored this patient was we initially fabricated a cement retained provisional restoration on temporary abutments, so we can actually so we can contour the soft tissue the way we want it, and having a better emergence profile, so we can then transition those contours to the definitive restoration. And you can see here, you could appreciate the difference in the soft tissue profile between the healing abutment and the provisional restoration. And nowadays, if you don't want to fabricate provisional restoration, those customized healing abutment or healing cuffs are available, and they are available in multiple contour that you can customize for the patient. And after that, obviously, impression was made. In this case, we just made a duplicate of the patient provisional restoration that he's happy with. And from there, we designed completely the abutment that are fully contoured to allow good soft tissue support, good biomechanical features, and good aesthetic outcomes for the patient. And you can see here the full design. This is Dental Wing software that was utilized with the fabrication of these abutments. And here's the final abutment fabricated, completely patient-specific and completely customized. And now we can place the abutment, place the final restoration, which in this case was porcelain fused to metal restoration with even, because of the type of occlusion he has and the spacing we have, we even utilized having metal occlusal with this PFM restoration. Now, when we talk about anterior implants, the use of zirconia abutments, obviously, it provides a huge aesthetic outcome because of the color of the abutment, because of the transition of the color through the mucosa, and can result in a very, very successful outcomes for our patients. Nowadays, we do a lot of actually screw-mentable restoration. And the advantage of these restoration, they are actually designed as cement-retained restorations. So provide you with all the features and the advantages that cement-retained restoration provide, including the soft tissue support, the control of the position of the margin, the biomechanical features for good retention and resistance of the abutment, but then they are delivered in screw retained fashion by being cemented extraorally to eliminate all the excess cement and then deliver them in place. And those can be fabricated on custom abutment or prefabricated tie bases. My preference is to fabricate them on custom abutments. So they are, again, all the advantages of cement retained restorations are there, but also it results in better retention. It results in more fracture resistance for these type of restoration, and also better implant health long term. We actually just completed a master thesis comparing cement retained restorations fabricated on custom abutment versus tie bases. And we did a finite limit element analysis that shows actually you have less implant or less stress on the implant connection and the implant platform by the fabrication of screw-mentable restoration with CAD/CAM and custom abutments. You have a wider base, better distribution of the forces to the implant. Now, you can have restoration level technical complications, things like ceramic chipping, fractures, but you will have less complications like screw loosening, abutment fracture, implant fracture, and even bone loss around dental implants long term. So those are manufactured as two pieces. You have the crown and the abutment, which can be done at the same time. Then they can be delivered either as two pieces by the lab, and you can cement those chair side for your patient before insertion. The advantage of that is you could place the abutment, place the restoration, do all your adjustments, proximal contacts, occlusal contacts, do the final finishing and polishing of the restoration, then cement it. Or it can be delivered as one piece by the abutment already cemented in place. Obviously, if you have a tight proximal contacts, if you have to do any adjustments, you may have to then seat and remove the restoration several times. So there's advantages for each one of those approaches. How you fabricate these type of restorations? Obviously, you start with an implant level impression. This could be conventional or it could be digital, utilizing scan buds like what you see in this lecture. And then you send that to the lab. And something that you really should have is something called a split file design. This is very important file that you look at both the restoration design, but also the abutment design, and it can show you where the margins are placed, the soft tissue support, the screw axis, where it's coming from, and you can communicate with the lab about any changes you would like to have. These are screenshots taken from my phone, were emailed to me or texted to me by the lab to take my input on the abutment design and asking for any changes. And I could simply text back and say, can you increase the mesodistal width? Can you reposition or move the screw axis in whatever direction, and if that's possible or not. And at the end, once you approve it, the abutment can be manufactured, and at the same time, the restoration will be manufactured by the lab. And in this case, this is a restoration that came back already bonded in place, and we just seated for the patient very, very precisely and very, very successfully. And we can see the initial implant and the final restoration, completely fully anatomic, very nice transition between the implant platform to the final margin and the soft tissue location that would allow for good tissue support and good health over time. What you would like to see, even with some of the research coming now for peri-implantitis, is if you have a nice transition and a nice contour that's convex in this area, those are implants will have less chances than if the implant was placed shallow and then we have an abrupt transition. For example, if this was going directly out and above, resulting in a very, very bulky contour next to the gingival area, that will become harder to clean, result in more accumulation of plaque and more chances for peri-implantitis to occur for these patients. Again, screw axis should be an ideal location coming through the occlusal surface of the posterior teeth, the parietal surface of the anterior teeth. And again, there are multiple techniques that can be utilized to reposition screw axis if needed. And again, also these type of restorations can be manufactured chair side with titanium bases, similar to the ones that you see here. They come in, again, different heights, and you probably should utilize the tallest tie bases that the patient can have, so you can have good mechanical retention also for the stability of these restoration. You can manufacture the full restoration in screw retained fashion for these tie bases, or you can actually utilize it to manufacture hybrid type abutments, for particularly the one made from zirconia, if you would like to have or to maintain titanium to titanium connection inside the interface, for example. And here is an example of that hybrid abutment. And while you would like to maintain titanium to titanium connection, there is some research that shows that with full contour zirconia restorations in lab studies over thousands of cycles of function, it resulted in wear inside the interface because you have a harder material, that's the zirconia, against a softer material, that's the titanium. So maintaining the same material contact may result in less wear. Is that supported by clinical trials and long-term studies? Absolutely not. However, we know that with ceramic abutment, zirconia abutment, there are more complications, things that abutment fracture, screw loosening. One way to try to overcome some of the issues is the utilization of tie bases and hybrid abutment design similar to what you see here. Again, you will need an implant level impression, and the lab can completely customize the abutment using CAD/CAM technology, and even can fabricate the whole restoration in cement retained fashion similar to what you see here by the build of the restoration on the final abutment. When we start talking about the aesthetics of the abutment, sometimes we may just think about zirconia type of abutments. And in reality, what we should be thinking of is what can achieve very good aesthetic outcome for the patient, but at the same time, maintain health, soft tissue stability, and functionality long term. So sometimes it's what makes the dentist happy versus patient happiness. And sometimes you'd like to walk that fine line. You'd like to achieve a very good aesthetic outcome similar to what you see with this picture, but you would like that to be maintained over time. So if we ask ourselves, what should the ideal abutment looks like? Let's look and be informed by data about what type of material we should be using, the type of connection for the implants and the abutment. And if you look at some of the systematic reviews looking at from the implant literature, you can have a lot of complications that happen with dental implants. Those can be divided into biological outcomes or biological complications, technical complications, and aesthetic outcomes and aesthetic complications. Generally, dental implant therapy is very, very successful. The survival rate at 5 years, about 97.2%. So biological complications can happen, but generally it doesn't happen early on with the implants. It happens more, 10 years or after, and things like peri-implant mucositis, bone loss, and of course, as we discussed, the implant abutment can play a significant role. So very good material, very good design, stable connection would result in much better biological outcome long term. Some of the technical complications that you mainly will face would be sluice abutment screw. And you see that in about 8.8% of the cases. Again, more stable connection, more robust abutments that have very good biomechanical features will result in less stress on the fixation screw and thus less screw loosening. But that's something that can happen, and what happens, similar to what you see in this picture with the abutment being loose, it can result in aesthetic problems, biological problems, and soft tissue inflammation around the implant. So we have to be very careful, do everything we can to actually have a very stable connection, and that stable connection to be there and stable over time. If we look at the aesthetic outcome, about 7.1% at 5 years aesthetic complication rate. So that can be actually at 5 years considerably high. You would like something around 95%, so 5% or less aesthetic outcome. So here's slightly higher, and again, that has to do with a lot of factors. It has to do sometimes with the implant placement. It has to do with the abutment design. It has to do also with patient-specific problems, things like presented with, thin biotype, which will result in more recession, result in reflection for sometimes of the implant or the abutment through the transmucosal area, resulting in lack of aesthetics. But also there are other things that we have to consider on the restoration side, shade, shape, contours of the restoration. And those are very, very important factors to consider. So, sometimes you might be dealing with a compromised situation like what you see here. A lot of bone loss, a lot of soft tissue loss. So achieving ideal result may not be possible, but you can achieve acceptable aesthetic outcome that can be maintained over time, and that's sometimes what you are looking for. But when resulting about choosing the material, something that's very important is the establishment and preservation of healthy soft tissue around implant abutments are very, very important long term. But the other thing that we have to consider is the bacterial contamination of the abutment or the microleak that happens around the connection, but also plaque accumulation around dental abutments. And if we look at the various dental abutment materials, actually the difference between those and these features, which is bacterial species around whether let's say zirconia or titanium, it is almost very, very similar. The difference is not statistically significant. However, you can see, and some of the recent studies show less accumulation around zirconia abutments because of the way they are manufactured and the way they are polished, while earlier studies show less accumulation around titanium abutments. Now, the color that's through the transmucosa is something that's very, very important, particularly with thin gingival biotype that can reflect the color through the gingiva. And for those patients to achieve better outcome, either the utilization of zirconia materials that's tooth colored and have, again, less reflection through the gingival tissue, or gold shaded titanium abutment, those can be recommended for these patients and result in a very, very good aesthetic outcome. The peri-implant tissue around the zirconia abutment, it mimics the color of the natural gingiva, resulting in very good optical and aesthetic results. But also the color of the soft tissue around titanium implant were in some studies significantly different to that of the natural teeth, resulting in reflection of the titanium or the grayish color through the soft tissue. So we have a huge advantage of a zirconia abutment versus titanium abutment. So if a titanium abutment is the the one to be utilized, probably plating it with golden color result in much better outcome and much less reflection of that grayish color through the transmucosal area. What about gingival discoloration? There actually was no significant difference between the use of titanium abutments and zirconia abutments in some studies, while in other studies show significantly higher discoloration with titanium abutments. So again, you will see more reflection of the color, more discoloration with titanium abutments, less with gold-shaded titanium and zirconia abutments. And here you can see a zirconia abutment resulting in a very good aesthetic outcome because of the huge optical and aesthetic properties that this material has. Now, if we look at the connection, I mean, it's clearly, the literature is clear on having a stable connection through internal conus type fit of those connections that result in more stability over time and less screw loosening. So nowadays, most implants provide this type of connection, of internal connection, and can be stable over time. Also, something to consider would be the platform switching of those abutments, moving the implant abutment interface away from the bone. So if there is actually any micromotion or leakage of a flora or of bacteria around the implant connection, it stays away from the bone, resulting in less soft tissue inflammation and bone loss over time. But again, with implant abutment interface, the connections, the technical complication with screw loosening and abutment survival is better, and the biological complications, which is inflammatory in nature, result in less peri-implant mucositis and peri-implantitis long-term, as we discussed. So factors to consider, again, the tissue biotype and the architecture, the implant abutment material, and the implant abutment design. And we discussed all of these, and these becomes even more important with patient presents with thin biotype, thin gingival tissue that can reflect the color through. For these type of patients, you would like to have very, very precise implant planning, sometimes even connective tissue grafting, the placement of the abutment with stable connection, and of course, utilizing more aesthetic materials such as zirconia or gold-plated titanium. But if we look at summary of the literature when it comes to abutments, at 5 to 10 years, abutment complications, both biological and technical, are more prevalent than implant complication. So the implant complications happen later, and the abutment complications can happen earlier. Things like screw loosening, aesthetic problems with particularly gingival recession. Again, internal connection offer potentially better biological and mechanical advantages to address most of the prevalent complications with implant abutment. And there is a limited aesthetic advantage for zirconia that sometimes may not outweigh the increased risk of failure. And that failure could be as a result of either screw loosening, abutment fracture, and in one piece zirconia abutments, potentially if you don't have stable connection, if there is a micromotion, over time can result in wear inside the implant interface that even result in the implant completely failing and require removal and replacement. So in summary, as we come to the end of this overview of implant abutments, patient-specific abutments actually provide huge advantages for the patient. They are designed and manufactured by CAD/CAM technology. They are preferred because they provide huge advantage from support of the soft tissue, control over the emergence profile, and providing huge aesthetic and functional advantages for the patient. Published data obviously will favor using conus abutment interfaces with internal connection. Those are more stable over time with less complications such as screw fracture and screw loosening. Titanium abutments offer durability with little sacrifice in the aesthetics, and aesthetics can be improved by the customization of the abutment with gold plating. However, zirconia abutments still can be utilized in the right type of patient and provide a very good outcome. And something that's very, very important is the submucosal design is very, very important and related to the tissue architecture and has huge effect on any risk of inflammation, risk of peri-implantitis, as we discussed. But sometimes that has to do also with the implant positioning. So careful planning in our implant cases from the treatment planning phase to the surgical phase and then the restoration phase would be the key for achieving a good and aesthetic outcome for our patients.